I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
My name is Megan LeMay. I am an assistant professor in general internal medicine at Virginia Commonwealth University School of Medicine. I spend most of my time as a primary care doctor and clinician educator, and also work in VCU's Motivate Addiction Treatment Clinic. You've already heard from Dr. Baccaretti about the treatment of a patient with addiction, and I'm really excited to be talking to you about medication-assisted treatment. In this topic, we'll talk about identifying candidates for medication-assisted treatment for substance use disorders. We'll describe the mechanism of action, efficacy, advantages and disadvantages of the FDA-approved medications to treat alcohol use disorder and opioid use disorder. So what is medication-assisted treatment? It's the use of medications in addition to psychosocial or behavioral therapies in the treatment of substance use disorders. I want to mention that it's important to view this not as replacing one addiction for another when giving the medication, but instead providing treatment of a chronic disease which is safe, efficacious, and well tolerated, and something thought of as prescribing medication for any chronic disease like hypertension or diabetes. Who's a candidate for medication-assisted treatment? Any patient with a moderate to severe substance use disorder would be a candidate. Patients who aren't currently using but who continue to experience strong craving for their substance would also be candidates. And also patients who would experience a significant negative consequence of recurrent substance use, such as worsening of a medical problem or legal issues. Before starting MAT, it's really important to have a comprehensive history and physical exam, including lab work and an assessment of kidney and liver function, as many of these medications are processed through the liver or affect them in some way, or the kidney. It's very important to have a mutual goal-setting conversation with patients. Abstinence from substance use is generally the gold standard goal, but that might not be every patient's goal to meet. And sometimes cutting back to safe limits of alcohol use, for instance, may be an appropriate goal for you to reach mutually with the patient. You should also assess a patient for risk of withdrawal and consider if they require medically supervised withdrawal. Always recommend psychosocial treatments to be paired with MAT. So what are the FDA-approved medications for alcohol use disorder? There are 3, Naltrexone, Acamprosate, and Disulfiram. For opioid use disorder, the 3 are Buprenorphine, Methadone, and Naltrexone. So let's start with the case of Miss Green. Miss Green is a 38-year-old woman with a history of alcohol use disorder who presents to primary care clinic saying, "I feel like I'm going to drink again." She has been drinking 6 to 10 12-ounce beers nightly for 15 years and has been unable to cut back on her own, and she lost a recent job and relationship due to alcohol use. She has never been in treatment before, but recently started seeing a substance use counselor, and she hasn't had any alcohol in 12 days. She is experiencing significant craving for alcohol. In addition to alcohol use disorder, she has a medical history of chronic kidney disease, and her glomerular filtration rate is 24. So in considering the medications that may be an option for Ms. Green, the first would be naltrexone. So naltrexone is an opioid antagonist medication. It works by decreasing the craving and pleasurable effects of alcohol by decreasing that opioid-mediated dopamine release and beta-endorphin release from alcohol use. It's available in a daily oral formulation and a monthly long-acting injectable. How efficacious is naltrexone? Its efficacy has been established in multiple meta-analyses and systematic reviews. The NNT is the number needed to treat, meaning how many patients would you need to treat with naltrexone for one to achieve the expected outcome. To put some of these numbers in perspective, the number needed to treat for statin medications for the primary prevention of cardiovascular events is likely somewhere around 100. The number needed to treat for naltrexone to prevent return to any drinking is 20, and to reduce heavy drinking is 12. As far as the efficacy of the long-acting injectable form, it is associated with a decrease in heavy drinking, but we have less evidence for its return to any drinking or abstinence. Some of the advantages of naltrexone, it's available in either a once daily or this long-acting injectable form that only needs to be given every 30 days. And it tends to work especially well for patients with significant craving because of that sort of dopamine opioid pathway that it works on. Some of the disadvantages, as far as side effects, they are rare. Naltrexone is generally well tolerated, but unusual but possible side effects include headaches, nausea, vomiting, fatigue, and dizziness. Some of the extremely rare but serious complications include hepatotoxicity. So naltrexone should actually be avoided in patients with decompensated cirrhosis or if their transaminases are greater than 5 times the upper limit of normal. It's important to monitor liver enzymes regularly when you prescribe someone naltrexone. The only contraindication really to naltrexone use is current or planned opioid use. Because it is an opioid antagonist, if you're currently using opioids, it would antagonize that effect. If you have something like an upcoming surgery planned that would require opioid medication, this would also be a contraindication. The next medication that might be an option for our patient is acamprosate. The mechanism of action of acamprosate is a little less well understood, but we believe it inhibits neuronal hyperexcitability, which is common after withdrawal of alcohol that's been given for long periods of time. And we believe it works with glutamate, the sort of excitatory neurotransmitter at the NMDA receptor. It's administered orally as a 3 times daily dose. Its efficacy, its number needed to treat for return to any drinking would be 12, and 9 patients to be treated to reduce heavy drinking in 1 patient. Some of the advantages of acamprosate, it is likely to be particularly helpful in the immediate post-withdrawal period because of its management of that neuronal hyperexcitability that's present after you withdraw alcohol. Some of the disadvantages, again, it's generally safe and well tolerated with very few side effects and no drug-drug interactions. Rarely patients may experience diarrhea. One important thing to note about acamprosate is cautious use in patients with renal failure. In patients with a GFR between 30 and 60, you should reduce the dose. But if patients have a GFR less than 30, as our patient that we're discussing now does, you should avoid use of acamprosate. And the other major disadvantage is that it's a 3 times daily medication, and it's quite difficult for patients to recall or work that into their lives to take a medication 3 times a day. I want to take a moment to compare the efficacy of naltrexone and acamprosate, and a comparative effectiveness analysis of the two medications essentially found that there was no significant difference in their efficacy. The third and last medication that we could consider for our patient is Disulfiram. Disulfiram is sort of the oldest and potentially most known medication for the treatment of alcohol use disorder. It works by inhibiting aldehyde dehydrogenase, which is that second step in the breakdown of ethanol to acetate, and leads to the buildup of acetaldehyde, which is toxic and makes you feel very ill. If patients were to drink after taking this medication, they would experience flushing, sweating, tachycardia, nausea. It's sort of described as the worst hangover you can imagine that comes on all of a sudden. As part of its mechanism, it does not affect a patient's desire to drink alcohol, and it's available in a once daily oral dosing. Disulfiram's efficacy is essentially limited by its tolerability and adherence. Because of this sort of terrible effect of drinking when you take it, most patients, if they think they might drink, just don't take it. So adherence in unsupervised settings is as low as 20%. It really has mixed results in meta-analyses. One of the potential advantages of disulfiram is that if it's given in a directly observed setting, it can be more effective, and it also has some evidence for using it as needed. For example, if a patient has been abstinent from alcohol for a significant period of time but has a planned event or party coming up, they may start the day feeling sure they won't drink but end the day at night feeling like they might. So if they take disulfiram as needed that morning, they know they can't drink later. Some of the disadvantages of disulfiram use, you really need to avoid alcohol use for at least 24 hours prior to administering it to avoid that toxic disulfiram reaction. And you need to warn patients about that expected reaction if they were to drink, and sometimes even if they were to allow alcohol-containing mouthwash or cooking with alcohol, they may have the same reaction. It should be avoided in patients with heart disease because of that tachycardia that it can cause as part of the disulfiram reaction. And some of the common side effects include rash, headache, fatigue, and a metallic or garlic taste. Some of the more rare but very serious side effects of disulfiram include optic neuritis, peripheral neuropathy, hepatitis, including cholestatic or fulminant hepatitis and hepatic failure. And disulfiram has several important drug interactions. So if you were to prescribe this for a patient, it would be very important to do a thorough analysis of drug interactions with their current medications. So how do we decide which medication is appropriate for a patient? I think the first thing to mention is that naltrexone and acamprosate are considered the first-line FDA-approved medications for the treatment of alcohol use disorder. You also need to consider a patient's other medical conditions and other medications they take. Costs and insurance issues are always important to consider when you're prescribing. And the ease of administration, how often do you need to give it, and how easy would it be for a patient to take it? So in considering Miss Green, our 38-year-old woman with alcohol use disorder, who also has significant chronic kidney disease, what medication should we choose for her? Likely naltrexone would be the best option for Miss Green based on the fact that it is a first-line medication and we can't give her acamprosate because of her kidney disease. How long do we treat patients with these medications? The ideal duration is not established, but in general, we recommend at least 6 to 12 months or longer, basically until the risks outweigh the benefits of continuing treatment. When you are deciding whether or not to take a patient off of the medication, you should consider if a patient has maintained their abstinence, if they have diminished cravings, and if they're engaged in ongoing recovery. Elderly patients are candidates for the same pharmacotherapy as younger adults, but it's important to monitor them closely because they have are more likely to have other existing conditions and side effects. Pregnant patients, nursing mothers, and adolescents should really always be treated in an expert setting with experience in those populations. So let's talk about another patient case, Mr. Brown. Mr. Brown is a 26-year-old man with a history of opioid use disorder presenting for medication-assisted treatment after 48-hour inpatient opioid detox. He last used heroin 3 days ago. He works as a software engineer and lives with a girlfriend who does not use. He has established care with a substance use counselor. So what are the medication options for Mr. Brown? The first option to consider is buprenorphine. Buprenorphine is a partial mu-opioid antagonist, meaning it acts at the same mu-opioid receptor as other full agonists like methadone, oxycodone, or heroin, but only has partial effect there. So you reach this ceiling effect where above that effect you really don't get the same sort of euphoria or respiratory depression effect of other full opioid agonists. It's available in several formulations. The most common is probably a combination product of buprenorphine naloxone that comes as a sublingual tablet or film. I want to note that, so naloxone is an opioid antagonist, and it's only present in this as a deterrent. Because naloxone is not orally available, it's only there for use if a patient were to attempt to inject the medication. It would act to antagonize the opioid effect. It's also available as a monoproduct, just buprenorphine, and as an extended release subcutaneous injection, which is relatively new and administered approximately every 30 days, and a buprenorphine implant that is placed every 6 months. As far as buprenorphine's efficacy, it's had multiple randomized controlled trials and meta-analyses to show that it is more effective than placebo in maintaining people in treatment and reducing opioid use. And I also want to mention that there is evidence that buprenorphine is effective when prescribed within the primary care setting. The major advantage of buprenorphine therapy is that it is an office-based treatment. It can be prescribed through any office, including primary care, and does not need to be given a specialized setting or inpatient setting. It also has a lower risk of side effects and abuse when compared to methadone, and has these long-acting options like the subcutaneous injection and implant. Some of the disadvantages of buprenorphine, one is that it's not more effective than methadone, which is the longest used and treatment for opioid use disorder and has the most evidence for its efficacy. You also must be in withdrawal to initiate buprenorphine. Because it has this strong affinity for the mu-opioid receptor, it will kick off any full agonist that's sitting in there and cause something called precipitated withdrawal, which is sort of fast and hard opioid withdrawal that's very difficult to tolerate. If a patient, though, is in enough withdrawal, it sort of fills that opioid receptor and instead helps alleviate withdrawal symptoms. Some patients, though, find it difficult to tolerate the withdrawal you need to be in to initiate buprenorphine. Some of the side effects are sedation, constipation, nausea, and headache. As far as the overdose risk is concerned, the risk of respiratory depression is limited by that partial activation of the opioid receptor, but it can be overcome and could possibly overdose if taken with other substances, especially benzodiazepines. The next medication we can consider for our patient is methadone. Methadone is a full mu-opioid antagonist, which is long-acting. And we use it for the treatment of opioid use disorder because we maintain patients with a high level of opioid tolerance with methadone, which limits its euphoric effects. Methadone, as I mentioned, is the longest used and most effective treatment for, as far as medication is concerned, for the treatment of opioid use disorder. There are numerous randomized controlled trials and meta-analyses that show a decrease in the number of opioid-positive urines. And in addition to that, patients on methadone are 4 times more likely to remain in treatment and have decreased rates of infectious disease transmission and crime compared to placebo with psychosocial treatment. Some of the advantages of methadone, as we mentioned, you don't need to be in withdrawal to initiate methadone therapy because it's also an agonist, and it has the longest use and best record of efficacy. Some of the disadvantages, the major one is that methadone can only be prescribed at federally recognized opioid treatment centers, or OTPs, and is not available as an office-based treatment. When you initiate therapy, patients need to present for daily dosing at a center, which, depending on if a patient has a job or lives far away, may or may not be an option. Methadone also has more common side effects: constipation, sedation, sweating, many medication interactions, and the potential for cardiac arrhythmias, including prolongation of the QT. There's also a higher risk of overdose, as it's a full mu-opioid antagonist, and side effects when you compare it to buprenorphine. The third medication that we could use for our patient, we've already mentioned, which is Naltrexone, which is the opioid antagonist. Just to mention a few specific things as it applies to the treatment of opioid use disorder, its efficacy is limited by poor adherence to the oral and long-acting injectable formulations. But when adherence is enforced, such as a court-monitored program, it's likely to be more effective. A patient must be free of opioid use and complete with all of their opioid withdrawal symptoms before you initiate this, as it's an antagonist and could precipitate withdrawal. So how do we choose a medication for Mr. Brown? Well, we need to have a shared decision-making discussion with him about the 3 potential options: the risks, benefits, costs, and interactions with other medications or medical conditions, and what's available in his area. We should recommend that he get medication-assisted treatment versus just psychosocial treatment alone. How long should we treat someone with medication for opioid use disorder? This is an individualized discussion with the patient based on their goals and their risk of relapse. Generally, we continue these medications for an extended period of time, again until the benefits, as long as the benefits outweigh the risks. This may be up to years for patients because, unfortunately, when we discontinue these medications, even years later, there is a risk of relapse. When it is time to come off of the medication, weaning agonist therapy is a very slow process. Again, elderly patients are candidates for the same pharmacotherapies and just need to be monitored closely. All pregnant patients with opioid use disorder should be offered medication-assisted treatment with buprenorphine or methadone in an expert setting, and this is more effective for them than supervised withdrawal. Adolescents are also candidates for medication-assisted treatment in the expert setting. So in conclusion, medication-assisted treatment is effective treatment for substance use disorders and should be recommended for all patients with moderate to severe substance use disorders. The FDA-approved medications for the treatment of alcohol use disorder are Naltrexone, Acamprosate, and Disulfiram. And for opioid use disorder, they are buprenorphine, methadone, and naltrexone. The choice of medication therapy should be a shared decision-making process with patients that includes discussion of the risks, benefits, costs, and availability of medications. And MAT should be paired with psychosocial or behavioral treatment for substance use disorders. So I just want to thank you for talking about this topic with me. And in the next topic in this module, we'll talk about how and when to safely refer patients for specialty addiction treatment. Thank you.